Preko, who is the project director at ICAP, Columbia University, for the HIV Coverage Quality and Impact Network. He leads projects dedicated to improving differentiated service delivery for people living with HIV and supports experience sharing, peer-to-peer learning, and collaborative problem solving. Please welcome Dr. Drake.
Thank you very much, and thank you to the organizers for inviting Sequin to make this presentation. I have two disclaimers to make. Since morning, you've been listening to TB experts and experts in the field. So my first disclaimer is that I'm not a TB expert. So what I'm going to share with you is the voices from 7 countries that met recently to discuss TB preventive services in the context of DSD. So my second disclaimer is that what I'm going to share with you is the voices of those 160 participants, not my view. Okay, so, but I cannot start without discussing what I do. So I'm going to start with what I do and then take you through the meeting and some of the take-home messages from that meeting. So I work for Sequin, and Sequin stands for HIV Coverage, Quality, and Impact Network. It's a South-to-South learning network designed to work with countries to scale up differentiated service delivery. It's funded by the Bill and Melinda Gates Foundation and convened by ICAP. So the main goal of Sequin is bridging the gap between policy and practice. You all agree with me that when a new policy comes up, the rate of uptake and scale up is different. It varies from country to country, and so bringing countries together to learn from each other, to share best practices and challenges actually helps to facilitate and support other countries also to scale up the uptake. So we focus on 3 main activities: South-to-South learning. One of the main things we do here is multi-country workshops, and one of which is what I'm going to share the lessons with you. We also provide focused technical assistance and also knowledge generation in order to catalyze scale-up using new ideas. So currently, there are 11 countries participating in the network. 7 of these countries were at a workshop where we discussed HIV differentiated service delivery opportunities and challenges for TB prevention and care. It was in Lusaka in March. So my presentation is going to focus on key messages from this meeting. So this was a meeting co-hosted by ICAP, the Sequin Network, and WHO, in recognition of the fact that as we shift people from more intense models to less intense models, it provides some challenges with respect to TB HIV services, because as we all know, most of these TB HIV services require people to come to health facility more frequently. So as patients are coming less frequently because of differentiated service delivery, this poses challenges that we thought needed to be discussed. So we brought together TB experts, HIV and DSD experts to exchange experience, best practices, and also share tools and other resources that they are using. We had over 160 participants from the 7 countries. Typical for Sequin workshops, country representatives include ministries of health, donors, implementing partners, civil society. And of course, we also bring our international partners like WHO, Global Fund, UNAIDS, and PEPFAR. So the first key take-home message is on TB screening and case finding. So as I said earlier, we recognize the fact that people are coming to facilities less frequently because of differentiated ART delivery. In most countries, they come once or twice in a year. And as a result, opportunities for TB screening is less. So in some countries like Ethiopia, where their model of care is 6-monthly appointment spacing, you realize that they don't have any complementary TB screening in between those 6-monthly visits. In other countries like Zimbabwe, where they have scaled up community ART refill groups, the expectation is that additional TB screening will be happening quarterly at the community. But the challenge is that they are not sure, the extent to which this is actually happening. So the first illustrative policy question that came up is, what is the minimum frequency for TB screening for people in less intensive differentiated ART models? We know the current practice is that people try to screen recipients of care anytime they engage with a health facility. But if people are in less intense models coming every 6 months, what is the minimum expectation for TB screening in terms of the frequency that they should be screened? So for implementation science, the main question here is whether TB screening provided by lay providers is of the same quality or comparable quality with regards to the screening provided by healthcare workers. The next take-home message is on TB preventive therapy. So here, we realize that most countries are kind of focusing or prioritizing TPT for patients who are initiating ART. And so those on differentiated ART models or those receiving less intense models are more or less not eligible for TPT because of the requirement to come every month when you start TPT. And we think that this provides this is a missed opportunity, actually, for countries where TPT uptake is very low, because by definition, patients in differentiated ART models are those who are doing very well, those who are retained. And so if we are not providing TPT for them, it's a huge opportunity. So the question there is, shouldn't TPT targets and indicators include all people on ART as a denominator rather than those who are initiating ART? And in terms of implementation science, we are wondering if TPT delivery in the context of less intensive differentiated ART models is feasible and acceptable, and whether the shorter TPT regimens will facilitate this. There was a huge conversation around community engagement. One of the things that the Sequin network does is provide platform for recipients of care to give us feedback, to contribute to the conversation and to make sure that their voices are heard. So we had a pre-meeting for recipients of care, and in that meeting, they tried to help us understand what meaningful community engagement is. And so they define community engagement as structured, meaningful, supported, and accountable engagement of people living with HIV. In terms of TB-HIV integration into DSD models, the meeting recognized that it is critical to scale up integrated DSD and TB-HIV services using a bottom-up approach so that we engage the recipients of care and they tell us what they think will work best for them, rather than we sitting up here and designing something and, trying to push them to accept. Another thing that was mentioned is the fact that we need to ensure that recipients of care actually have a voice and not just a seat when we have these discussions for guidelines and other activities around implementation. Oftentimes, we just invite them to come and endorse what we have decided on. But they really think that we need to make sure that they have a voice in the decision making and not just being invited to rubber stamp something that we have done. So I will now go into some model-specific opportunities and challenges. The first one is the facility-based models. Examples here are fast-track, appointment spacing, and adherence clubs. So in these models, they are facility-based. So the challenge here is the fact that there will be fewer opportunities for TB symptom screening compared to more intensive models. I think I mentioned earlier that in this fast-track model, patients, just to explain for the sake of those who are not in the ART arena, the patients come to the facility, they just pick their drugs and go. So although they're in the facility, they don't really interact with clinicians. So they just go straight to the pharmacy, they pick their drug, and they leave. And then, of course, for appointment spacing, they get more refills per visit, so maybe 3 months or 6 months. So in such a model, what happens is that the opportunity for TB screening is reduced as compared to models where they come monthly, for example. And then, of course, with the absence of a wraparound community support, you realize that the issues of adherence for TPT and ART may be a challenge. And of course, if also TPT will require monthly visits, so it becomes a challenge for those in this appointment spacing to uptake TPT, becomes a disincentive for them. In terms of opportunities, because they are coming to the health facility, if they get screened, the expectation is that the screening will be of the desired quality, and so we'll be able to identify TB cases, and of course, it will be easy to link them to TB diagnosis for those who screen positive. Also, the opportunity for screening for adverse events for INH also will become easier. For community-based models where there is clinical services provided, in this case, if TB screening is not part of the package, again, then there will be a missed opportunity for TB screening. If ART and TPT are not provided in the same schedule, then also uptake of TPT will become a disincentive. In terms of opportunities, the fact that there will be quarterly community-based TB symptom screening by a healthcare worker, we will expect that the TB screening will be of the right quality. And also, if ART and TPT are dispensed on the same schedule, then we will be able to increase uptake of TPT. The other community model is the one where there is no clinical services provided. And so again, the opportunity for TB screening will be a challenge, and the opportunity for screening for adverse events for INH also will be a challenge. But then it provides an opportunity for integrating ART and TPT, and also to decrease the frequency. As patients come to the facilities less frequently, the risk of getting TB will be minimized. I'm sure we've all seen some of these ART clinics where a lot of patients are packed in a cul-de-sac and airflow is in just one direction, So if patients are coming less frequently into such an environment, we expect that the exposure to TB will be reduced, and therefore the risk of getting TB will be minimized. And the final community-based model is the PODI, which is, I think, is implemented by DRC. Here it's a peer-led community-based distribution model with adherence, support, and symptom screening. In this model, the questions here is whether the TB screening done by these peers will be of a good quality compared to that done by healthcare workers, and whether screening for INH also will be of the desired quality. But it has quite a lot of some very important opportunities where the peers can, of course, support each other. They can provide counseling and adherence support for TPT. They can also help screen for TB, and uptake of TPT will increase if both are provided in the same schedule. So to summarize the network consensus points, as HIV programs shift tens of thousands of people to less intensive differentiated ART models, coordination and harmonization between HIV and TB programs is critical. And I think we've been talking about this coordination for TB HIV for a very long time, but I think this provides another opportunity for us to see how best to strengthen this coordination at the program level. And the new differentiated ART models, the overall consensus from the participants is that it provides more opportunity than a challenge for TPT, for TB preventive service integration. Also, conventional practices not supported by evidence may need to be recognized. For example, the monthly visits to health facilities for patients on TPT. We know this is good practice, but it's not evidence-based approach. So is this something that we can look at it and, change the practice so that TB and ART services can be integrated. Recipients of care also needs to be in the center of these discussions, and I think that has been the discussion since morning. We've been talking about the patient-centered approach and having the recipients of care at the center of the decisions that we make. So these are the consensus from the 160 participants from the 7 Sequin countries. Thank you very much.